get dressed for school. What are you doing? I was like, can't you just sit still and play with a doll? But no.
So you missed the lecture yesterday on how like infusion and testosterone makes boys like very active.
Oh, thank God I didn't take any then.
No, just the
Oh,
surge.
just the surges that they get normally.
Mm-hmm.
Okay, good. I was like, well, there's no push for not taking supplements.
No, it's just like
it's just their natural. There's something. I have a sister. My mother's like, yeah, 2 girl children, and I've never seen anything like this. So, but it's fun. It is fun. A bit exhausting, but fun. All right.
Cool. It's on mute right now. If you just.
It is on mute?
no, it's not on mute.
It's not on mute. Okay. So now it's on mute. I just turned it off of mute. Good. You know what? I think it's best if I just maybe attach it here. Great. And then I can slide up, slide down with this, or I could use and I can use the mouse as the pointer. Fantastic. And I can just leave that right there. Cool. All right. Great. Okay. Perfect. All right. So we'll get started. Thanks for coming this morning. I'm Nataki Douglas. I'm one of the assistant professors in OBGYN in the Division of Reproductive Endocrinology, and infertility. I spend about 30% of my time seeing patients and the other 75% of my time doing basic and clinical work. So today we're going to talk about assisted reproduction. Just nothing to disclose. You have sort of the learning objectives of the things that we hope by the end of this talk that you are a little bit more familiar with. So fertilization in the body, in vivo, occurs once an egg is released by the ovaries, it's swept up into the fallopian tubes, fertilized here in the fallopian tubes. The embryo then begins to form and implants in the wall of the uterus. This whole process of in vivo fertilization is controlled by the hypothalamic pituitary ovarian axis. And so the goal of assisted reproduction is really to achieve fertilization in vivo or to achieve fertilization in vitro. And so we are able to take advantage of sort of the well-coordinated events of the HPO axis. And one of those is the menstrual cycle. So at the level of the uterus, women who are having clockwork normal menstrual cycles sort of have this nice regular cyclicity of this schematic here. That bleeding happens on day 1, an egg starts to develop. As the egg develops within the follicle, estrogen increases. The egg, when it is mature, ovulates. The follicle that remains is called the corpus luteum. This corpus luteum secretes progesterone. And so the uterus responds to these hormones by proliferation in this follicular phase, this phase of egg development. And then in the second half of the menstrual cycle, the secretory or the luteal phase is the progesterone-dominated phase. So the progesterone from the corpus luteum, which is the primary secretory product of the corpus luteum, now matures this endometrium, and implantation occurs sort of in the middle of the luteal phase if there is a competent embryo. And so we take advantage of both what happens at the level of the ovaries and what's happening at the level of the uterus to achieve successful fertilization. So when thinking about assisted reproduction, we have to think about, what is the real probability of conception? And so what we know is that egg and sperm need to get together for conception to form an embryo. But we realize that the day of ovulation of an egg, the day before ovulation or 2 days before ovulation, are the most likely times for conception to occur. That intercourse after the day of ovulation or beyond has almost zero chance of leading to a successful conception. When we think about the probability of conception, and I'm sorry, this is a sort of Mac to PC transition. When we think about the probability of achieving a pregnancy or conception in a singular menstrual cycle, what we know is that if we look at 12 cycles in a year, a cohort of healthy couples trying to conceive, the first 5 months are the highest chances of achieving pregnancy. So somewhere between 15 and 30% chance of pregnancy per month in the first 5 months of trying. Once a couples have been trying for 12 months or greater, there's less than a 3% chance of couples conceiving on their own. If we look at it another way, if we look at 12 months of follow-up, the actual cumulative pregnancy rate is about 85% after 12 months. So trying for 12 months, 85% of couples will successfully achieve pregnancy. So normal fecundability is about 20%. About 82 to 85% of couples are going to conceive within 12 months. And as you saw, fecundability decreased over time. By the time you got out to the 12-month mark, you were looking at 3% chance or less of getting pregnant. So fecundity is now the probability that a single cycle is going to result in a live birth. And so what this graph looks at is we're looking at the fertility rates, and the different lines are increasing time with years. And then we're looking at the mother's age at delivery. And what you can see is there's a pretty sharp decline from the 35 to 39 age group moving on of having a live birth per 1,000 women as a woman gets older. So fecundity is decreasing with a woman's age. So we define infertility as the failure to conceive after 1 year of frequent intercourse without contraception. So infertility is a medical condition that involves a couple and not an individual. And the prevalence of infertility, depending on the populations that you study, is about 7 to 20%. So a couple caveats. When we talk about infertility as 1 year of trying, we are now talking about women that are 35 years or under. Once you get over the age of 35, we now look at 6 months of trying as a time to be assessed for infertility. And the reason is just because of increasing female age as something that is non-modifiable, and that we know that fecundity decreases significantly after the age of 35. And so primary infertility is infertility in a woman who has never conceived before. Secondary infertility, a woman has had a conception, whether that conception resulted in a live birth, a miscarriage, or a voluntary termination. It's secondary if she has been able to conceive previously. So why does fecundity decrease with age? Well, female fertility declines with age. And so this sort of graph that we see all the time really calls age 37 as the point where fertility starts to decline more rapidly than it had in the past. But what we know when we evaluate women, starting at the age of early to mid-20s to age, 44 and above, that this decline in fertility really depends on, it's person-dependent. There's some element of family history. If your mother had early menopause, you're probably more likely to have early menopause. But it is not the age of 37. That may be sort of the population average, but female fertility can decline for any particular woman as early as the early 20s. So if we think about a case, Mary is 32, Jack is 36. They've been trying to conceive for 2 years. Prior to getting married 2 years ago, Mary had been on birth control pills. They have unprotected sex 2 to 3 times a week. They're both healthy. They don't have any medical problems. Mary exercises regularly. She recalls that she's had about 7 periods in the last 12 months. Her menstrual cycles were also irregular prior to starting the birth control pill years ago, but she's been off the pill for the past 2 years, and it seems like the cycles are pretty consistent with, not coming every month. So what are the causes of infertility? So female factor has a lot of sort of subgroups within it. First being diminished ovarian reserve, ovulatory dysfunction, tubal damage, endometriosis, and sort of endometrial factor, and then cervical factor. Male infertility is a category of its own, and then unexplained is what we would, a diagnosis we would give to a couple where we've done a thorough evaluation of both partners, and we can't find any reason in terms of laboratory values, ultrasounds, why the couple has not been able to conceive. So if we sort of look at the breakdown from the Society of Assisted Reproductive Technology in 2010, and I'm sorry, this is a little bit blurry, multiple factors, both female and male, makes about 18% of infertility diagnoses, and then male factor alone, again, makes up another 18.8%. So these are the most common diagnoses for patients who had been seen for fertility treatment. And then ovulatory dysfunction, about 7%, diminished ovarian reserve, about 12%, and then this unexplained is coming in at about 14% of couples will get the diagnosis of unexplained infertility. So ovarian reserve is sort of a big one. As I mentioned, it's a non-modifiable factor, and ovarian reserve is defined as the quantity and linked to that the quality of the remaining oocytes or eggs in the ovaries at a given time. So as women, we're born with all the eggs that we are ever going to have. We have the most number of eggs when we are in the womb at mid-gestation. And by the time we enter puberty, we have about 300,000 eggs to ovulate. And then by the time we are at menopause, there are a few hundred to about 1,000 eggs that are left. And so this is what makes sort of ovarian reserve the biggest and a non-modifiable factor for infertility. And this decline in the number of follicles we have, as I mentioned, varies with a woman's age and varies per individual women. So we know that quantity and quality are linked, and that age is a big risk factor. So the percentage of abnormal or aneuploid oocytes increases with age. At age 35, about 10 to 40% of the oocytes are going to be abnormal, but by age 45 and greater, up to 100% of the eggs are abnormal. And linked to that are going to be miscarriage rates. So miscarriages in spontaneous pregnancies and also in assisted reproduction pregnancies increase with increasing age. So less than age 35, about 7 to 15% of pregnancies will result in spontaneous miscarriages. However, once women are 40 and above, 30 to 50% of pregnancies will result in a spontaneous loss. And most of these losses are happening, somewhere before 8 weeks pregnant. And the reason that the pregnancy is lost is because it's typically a chromosomally abnormal conception due to poor egg quality related to female age. And so we also know that ovarian reserve speaks to quantity as well as quality, because women who have decreased egg reserve, decreased numbers of eggs, have a higher chance of having abnormal pregnancies. And so that's how, even though ovarian reserve is really a number of eggs you have left, quantity and quality are linked. So as we said, female fertility declines with age. So how do we measure ovarian reserve? So again, we take advantage of the HPO axis. And so what happens is that follicle-stimulating hormone and estrogen are in a feedback loop. And so the eggs in the ovaries are maturing. When you have adequate eggs and adequate follicles, you have plenty of estrogen. When your estrogen levels decline, the FSH coming from the anterior pituitary will increase it senses the depletion of estrogen, the depletion of follicles, and so FSH increases to try and increase stimulation to the ovary. Another marker of ovarian reserve, which is seen today as sort of the best marker, is AMH, or anti-Müllerian hormone. This is a hormone that's produced by the small follicles of the ovary and is thought to be the best and the most stable readout of the ovarian follicle pool. And so it's a blood test that we measure. It can be measured at any point in the cycle. It can be measured when you're on birth control pills. It can be measured when you're pregnant, because that pool of follicles, that resting pool of antral and preantral follicles, is stable throughout the cycle, stable regardless of the medication you may be taking. So AMH is what we're using most often now to evaluate ovarian reserve. So the sort of caveat with measuring ovarian reserve is that when we determine that ovarian reserve is low, it gives us a pretty good indication of why a woman has not been able to get pregnant, or why a couple has been unable to conceive if all factors are normal but egg reserve is diminished. However, we see many women, many couples where ovarian reserve is actually normal and they still have been unable to conceive. And so we're always happy to see that there are plenty of eggs to work with, but certainly a good ovarian reserve is not necessarily reassuring or a guarantee that pregnancy will be readily achieved. So assessing ovarian reserve, we use the FSH and estradiol early in the menstrual cycle, typically day 2 or day 3. We have to measure them in combination because, as I mentioned, there's a feedback loop. And so we need to know that both levels are normal in order to say that a woman has normal ovarian reserve. Anti-Müllerian hormone measured at any point in time in the cycle, and those are blood tests. When we look at the ovaries, we can also get an idea of the ovarian reserve. And so we look at antral follicles within the ovary, and we can also measure the ovarian volume. A Clomid challenge test and inhibin B are also tests that had been used much more readily in the past to speak to ovarian reserve. So this is an ultrasound of an ovary. The antral follicles are these little black circles here. They measure 2 to 9 millimeters in size, and so we literally count the number of follicles that we see as an indicator of ovarian reserve. When we have more than 12 of these follicles in a given ovary, we start to worry about polycystic ovary syndrome, which we'll talk about a little bit later. We also can measure the ovarian volume, as I mentioned. So we measure the volume by basically taking measurements of this ovary in the 2 dimensions, turning the ultrasound probe so that we can get the 3rd dimension. And so those are ways to have ultrasonographic markers of ovarian reserve. And typically, we take the combination of blood markers, ultrasound markers, and a woman's age when sort of counseling her in terms of 1, what's her ovarian reserve, and then 2, the overall likelihood of a successful pregnancy. Because a successful outcome is age-related, more so than anything. Young women with lower ovarian reserve will have a more successful chance at conception and a live birth than older women with the same ovarian reserve. So ovulatory dysfunction is another reason that women have difficulty conceiving. Things that can cause ovulatory dysfunction: polycystic ovarian syndrome, hypertrophic hypogonadal anovulation, which is sort of the phenomenon where the HPO axis has shut down because there is incredible stress, whether it is stress in the body from anorexia, stress in the body from excess exercise where the cortisol levels are really high. It's basically just not a good time to reproduce, so you're not ovulating. Plenty of eggs are typically there, as in polycystic ovary syndrome. Typically plenty of eggs are present, but the HPO axis is not intact to signal clockwork ovulation. Hyperprolactinemia, so elevations in prolactin, can also lead to ovulatory dysfunction. And then thyroid dysfunction, both hypothyroidism and severe hyperthyroidism can lead to ovulatory dysfunction. So the most common of these is really PCOS, and we'll talk a little bit more about that. So how do you determine if someone is ovulatory? Really, history is almost the best and the best sort of marker to determine if someone is ovulating. If someone reports clockwork menstrual cycles, menstruating monthly, within a day or 2, they can predict their menses is going to happen, or especially if they're getting symptoms, premenstrual symptoms, chances are that that woman is ovulating. When women report that they're not having periods frequently, or they're having periods that are, maybe 35 days apart and then perhaps 50 days apart, that suggests that they are not ovulating. And we call that oligomenorrhea, and certainly the absence of menstruation, amenorrhea. To really determine that one is ovulated, you can measure body temperature in the second half of the cycle. So progesterone causes a small rise in body temperature, kind of laborious to do because body temperature needs to be measured at the same time every morning before stepping out of bed. And it also tells you that you've ovulated, which is not really helpful in terms of conceiving, because if you've already ovulated, it's not going to help you time intercourse. Urinary luteinizing hormone, or LH, measurements are probably the best in terms of helping couples time ovulation, determining that a woman is ovulating, and also help for the purposes of getting pregnant. When you detect the LH surge in the urine test, it means that ovulation is probably going to happen somewhere between 24 to 36 plus hours after the surge. And so we instruct patients that if they're using the ovulation predictor kits, that they should detect, when they detect a positive, they should have sex that night and the night after, because that would then allow for intercourse prior to the day of ovulation. As we discussed, after ovulation is not going to be useful for conception. Now, a blood test will probably be the best marker, again, laborious, but to determine that someone is ovulated. And so progesterone levels greater than 3 in the second half of the cycle will indicate that indeed ovulation has happened. Polycystic ovarian syndrome. So again, these follicles that we're looking at, they're small. They're 2 to 9 millimeters in size. And when we look at PCOS, there are 2 out of 3 things are needed for the diagnosis of PCOS. And one of these is the appearance of the ovaries. And so a typical PCOS ovary is called the sort of string of pearls, where the follicles are on the periphery and you have increased ovarian stroma in the center. More than 12 of these follicles in any arrangement, whether they be the string of pearls or whether they be dispersed throughout, gives you what's called a polycystic appearing ovary. Gives you one of the diagnostic criteria for PCOS. This is what the ovary would look like in an actual slice through an ovary. So the other diagnostic criteria for PCOS are irregular cycles, menstrual cycles, and or increased hair growth in a male pattern, or blood tests showing increased androgen levels, looking for testosterone levels. But again, this is sort of the most common etiology of ovulatory dysfunction, and something that we see commonly in terms of women, especially young women who have been unable to conceive. So if we look at tubal factor, you must have at least one patent fallopian tube in order for egg and sperm to meet. And things that can cause tubal damage: pelvic inflammatory disease, so a infection that has oftentimes started at the level of the cervix but has been untreated and so then becomes a pelvic infection, can lead to scarring and damage and occlusion of the fallopian tubes. An abortion, whether it be a voluntary termination of pregnancy or a miscarriage that has become a septic abortion, meaning that there is incomplete evacuation of the products of conception, and the woman has now ended up having a pelvic infection that can lead to tubal damage. Any kind of pelvic surgery can give you a risk of tubal damage. So a ruptured appendix that then is removed can lead to adhesions and scarring in the pelvis. Ectopic pregnancies, a pregnancy in a tube, can lead to tubal damage. And so the risk of tubal infertility is clearly associated with pelvic inflammatory disease. The sort of more times that you have PID, the higher the chance that you have tubal infertility. The risk of ectopic pregnancy, a pregnancy in your tube, is also increased with tubal disease. And so oftentimes we see patients who, when we look at their tubes, they have occluded tubes, and they say, well, listen, I've never had pelvic inflammatory disease. I don't know how this has happened. I've never had any surgeries. And what we can find is that they actually do have a higher incidence of having anti-chlamydia antibodies when we do a serum screen. And chlamydia is one of the sexually transmitted infections that can typically be sort of a silent infection. So how do we diagnose tubal factor? A hysterosalpingogram is the best way to determine whether or not tubes are open. So a hysterosalpingogram is performed in the early portion of the cycle. We want to make sure that the uterine lining is thin, so not as much exposure to estrogen. We also want to make sure that the woman is not pregnant when we're doing a hysterosalpingogram. And the way it's done is it's a bit like a pap smear in that a speculum is placed to visualize the cervix. A dye is injected through the cervix. That dye fills up the uterus, flows through the tubes when the tubes are open, and an X-ray is taken to visualize the patent tubes and the contours of the lining of the uterus. So these are normal hysterosalpingograms where you see flow through both tubes. An abnormal hysterosalpingogram could look like this. This is a T-shaped uterus after DES exposure. So this is a congenital anomaly of the uterus. Tubes are patent, though. This is a hysterosalpingogram with a normal uterus, but is showing you sort of dilated sausage-like tubes. These are called hydrosalpinges. So the tubes are inflamed, and the dye can sometimes spill out, but typically is gotten caught in the tubes. And this is what hysterosalpinx looks like at the time of surgery. Endometriosis. So endometriosis is the presence of ectopic endometrium in places other than the lining of the uterus. It has various stages. Sometimes endometriosis is only known because of a diagnosis on an incidental pelvic surgery, or endometriosis is also can be something that's suspected given a woman's history of pelvic pain, pain with intercourse, pain around the cycle, and then is diagnosed at the time of surgery. So managing endometriosis is oftentimes, managing the pain symptoms, and also managing and trying to prevent progression of endometriosis with birth control pills or with GnRH agonists that will sort of shut down the hypothalamic pituitary ovarian axis. And so clearly neither of those things is going to increase a woman's fertility. So there's been a sort of huge debate as to whether or not surgery should be indicated for all women with endometriosis. And, the most common thought now is that if you're doing surgery and you see endometriosis lesions, then you should remove them. You should try and, ablate endometriotic implants within the pelvis because it's a progressive disease. If you suspect endometriosis in someone who's trying to get pregnant, you don't necessarily have to do the surgery to diagnose it. You should focus on trying to get her pregnant. Whether or not you remove these endometriomas, so these are what we call chocolate-filled cysts in the ovary. They are classic of endometriosis. Now the thought is that if you're pretty certain that this is an endometrioma and it is not a malignant cyst in the ovary, just leave it alone, because what happens is removing this cyst requires shelling it out completely from the ovary, and then you're also removing good ovarian tissue. So there's plenty of data showing that women before surgery and after surgery for endometriomas have diminished ovarian reserve. So we now sort of leave these in place as long as they're not causing pain, as long as they are small, they're not rapidly growing, there's nothing suspicious about an endometrioma. We don't remove them for the purposes of achieving pregnancy. Cervical factor, something that has been talked about all the time and no longer really gets diagnosed, but the sort of take-home message is cervical mucus is really important for the transfer of sperm into the woman's reproductive tract. And so if mucus is hostile or thick, that this could really be a barrier to getting pregnant. And so estrogen is what really leads to good, healthy, clear, watery cervical mucus mid-cycle for the transfer of sperm through the reproductive tract. So we can characterize the cervical mucus by its stretchability and how it looks, but this is sort of what a good cervical mucus specimen would look like. And if you looked under the microscope, you have these nice little ferns to characterize the mucus. Now, no one takes samples of cervical mucus to determine whether it is hospitable. We actually use intrauterine insemination to bypass the cervix. So the sperm is inserted above the level of the cervix when we do an IUI or do artificial insemination. So any type of cervical factors, mucus hostility, if there's thought to be some anti-sperm antibodies at the level of the cervix, that is bypassed in assisted reproduction. Endometrial factor, oftentimes associated with a pregnancy outcome as opposed to ability to really conceive, except for submucosal fibroids and polyps. So if there is an actual physical lesion in the uterus, a pregnancy could implant there or fail to implant. And so when doing a workup for infertility, if we see fibroids, especially submucosal fibroids, or if we see polyps or adhesions or anything in the uterine cavity, we typically remove those surgically before initiating any type of assisted reproduction. Mullerian anomalies, more likely for adverse pregnancy outcomes, like a septate uterus or a bicornuate uterus, as opposed to an actual inability to conceive. And luteal phase defect is something that's been talked about for a long time, and sort of how to diagnosis has been in question. Years ago, we would diagnose luteal phase defect by taking a biopsy and trying to confirm that the endometrium is in synchrony with the ovary in terms of seeing secretory cells at the level of the endometrium. It's very hard to do. It's very hard to pinpoint that there's actual synchrony and in phase or lag by more than 2 days. So now we look at a woman's history and her cycle, and this is where ovulation predictor kits come in really handy. So that if a woman says, listen, I get my surge, on day 14, so I think I'm ovulating maybe around day 16, but oh, my period comes by day 26, that's a really short luteal phase. That's only 10 days. The luteal phase should really be an average of 14 days, somewhere between 13 to 15. And so that's where we would think, oh, maybe this woman does have a luteal phase defect, and the treatment for a luteal phase defect is supplementing with progesterone, which is really straightforward to do. It doesn't have many risks. So we don't do biopsies to really determine, whether or not the luteal phase is in sync. We usually just base it upon a woman's history. And also in the setting of IVF, if we've been doing, transferring in good embryos and a woman's not getting pregnant multiple times, then we start to think about, well, maybe there is something suboptimal with how her uterus is preparing itself. So male factor, we look primarily at a semen analysis. Unlike women, males make new sperm well into the 8th decade, and so a semen analysis is a good reflection of the quality and the quantity of the sperm. We oftentimes will have a semen analysis done, once and at least a month later to confirm what we find. So male fertility really doesn't decrease much with age, but certainly we do know that the incidence of chromosomal anomalies can increase with advancing male age. When we look at a semen analysis, we look to make sure that the overall volume is okay, indicating that there's no retrograde ejaculation and that we've likely gotten the entire semen specimen that was produced. We look at the concentration of sperm. There should be about 15 million sperm per milliliter. We look at the total count and motility and the progressive motility. So sperm can twitch in place, they can swim backwards, but what's important for a normal semen analysis is that at least 32% of the sperm are swimming forward. And then we look at morphology. So sperm have a textbook shape of their head, midpiece, and tail. And in the sort of latest edition of WHO, that greater than 4% of sperm should have a textbook normal shape. And the decrease in shape is oftentimes linked to the sperm's ability to penetrate the egg. Different sort of schools of thought think that it is an isolated morphology defect can really lead to infertility. Others don't, but sort of at Columbia in our practice, we really do believe that if everything is normal, but the percent of normal forms is diminished, that can be a significant contributor to the couple's infertility. So in terms of seeing couples, seeing women trying to conceive, really it's a lot of education to start. And part of it is, what are the overall chances, as we talked about, of pregnancy in a given month? We're looking at 15 to 30%, which is, less than half of the women are getting pregnant each month they try. What is good coital timing? The mature egg only lives for about 12 to 24 hours, whereas sperm can live in the human reproductive tract for up to 72 hours. So hence, intercourse prior to ovulation. We oftentimes encourage patients who are having timed intercourse to actually have sex before and after ovulation. Only reason being is it's really hard to time exactly when you're ovulating at home. And so if they're off by a few days, that is the reason for saying, sex sort of before and after, but not because we think that conception is really happening after ovulation. So back to Mary and Jack, we did a assessment of both Mary has polycystic ovary syndrome. She has her irregular cycles, 7 cycles in 12 months. We looked at her ovaries, and she had sort of the classic string of pearls appearance with greater than 12 follicles. Her tubes were open, and she had a normal uterine cavity. On semen analysis, everything was normal except there was decreased sperm motility at 20%, when overall motility should be 40%. So how do we approach a couple like this? Well, in someone who's not ovulating, it's called ovulation induction. And so that's what we would use for them. And someone who is ovulating, who is releasing a single egg every month and who is still not getting pregnant, it's called superovulation. We actually would like for her to release 2 to 3 eggs in a given month to increase the chances of conception in vivo. Timed intercourse, we instruct couples on appropriate coital timing. That's called timed intercourse, or intrauterine insemination, as I mentioned. So bypassing the cervix, this involves taking a semen specimen, washing it, processing it, and placing it in the woman's uterus shortly before she's going to ovulate. So how do we achieve ovulation induction or superovulation? They're oral medications, the most widely known and the one with the longest history, Clomid or clomiphene citrate. It's a selective estrogen receptor modulator. It is FDA approved for ovulation induction and superovulation. Another medication that's now been used for probably about the last 10 years is called letrozole or Femara. It's actually FDA approved for the treatment of breast cancer, but it is used quite often for ovulation induction and superovulation. Injectable medications, those are preparations of FSH and LH, synthetic preparations that sort of mimic what the anterior pituitary is secreting. And so these medications, Menopur, this is a combination of FSH and LH, or just recombinant FSH alone, are given on a daily basis to stimulate the ovaries to produce and mature eggs. In order to trigger ovulation, we use preparations of HCG because of its longer half-life than LH. So someone like Mary, we would give a clomiphene, an oral medication, is where we would start. The clomiphene works. It binds to the receptor. It blocks estrogen from binding, and so the hypothalamus pituitary believe that there is a low estrogen state, and so you start to increase GnRH and FSH production to stimulate the development of a follicle or multiple follicles. In terms of the logistics, we typically want to start at the beginning of a menstrual cycle, and we give Clomid or the letrozole oral medication for 5 days. And then we follow the development of follicles by ultrasound, sometimes blood work, but primarily ultrasound. And then we can instruct women on timing of intercourse, or we can prepare for an insemination. The risk of multiple pregnancies, yes, we're super ovulating oftentimes, and even when we try to just achieve ovulation induction, we may get more than 1 follicle. So there is a real risk of multiple pregnancies with any fertility medication. It's lowest with the oral medications, and it's primarily twins. There are some side effects to the medications, and they're primarily linked to the hypoestrogen state that Clomid and letrozole achieves in order to trigger that feedback of increased FSH, increased gonadotropins, and GnRH. And so the side effects are sort of almost menopausal side effects, where women will complain of feeling hot, having hot flushes, being nauseous. They'll complain of vaginal dryness, of mood changes. They're short-lived. It's a 5-day course of medication, and oftentimes women, when they know why this is happening, tolerate it pretty well. The one side effect of Clomid in particular that we don't tolerate is visual disturbances, blurry vision, any changes in vision. It is a rare side effect, but it certainly does happen, and it's a reason to stop the Clomid immediately and not take any more. So 80% of women who are anovulatory will actually ovulate on Clomid, but again, remember, the per cycle pregnancy rate is about 20 to 25%. So again, this is part of the education in that women need to anticipate that when trying to conceive, we give these treatments for 3 to 4 months before saying, oh, you know what, maybe this isn't working. If we are using injectables, like I mentioned, they're daily injections, usually for about 8 to 12 days, also starting at the beginning of the cycle. We definitely follow with estrogen and levels in ultrasound, and when we detect an LH surge, or we can trigger ovulation. The chance of multiple pregnancies is a bit higher with the injectable medications, and those have sort of fallen out of favor in lieu of IVF because there's much more control. So when talking about overall chances of pregnancy, when we combine injectable medications with insemination, that's sort of the highest pregnancy rates. If we just use injectable medications alone or just insemination alone for couples, cumulative pregnancy rates are lower. So we really do encourage women trying to conceive, couples trying to conceive, that we should be doing something on the woman's end, addressing the ovaries and the follicles, but we should also be doing inseminations of sperm to get the best chances. So ART, or assisted reproductive technology, is really the treatments that handle gametes outside of the body. So this is the in vitro fertilization, whether it be IVF alone, IVF with ICSI, intracytoplasmic sperm injection, egg donation, the pre-implantation genetic testing, egg freezing. All of this falls under the category of assisted reproductive technology. So the first test tube baby in the world, 1978, was Louise Brown, the first one in the US, 1981. IVF, as I'll show you, is pretty effective in conception. It's pretty costly per cycle. It's still about $15,000. Now everyone is moving towards a single embryo transfer of a good, healthy embryo, oftentimes with pre-implantation genetic testing for aneuploidy, or to rule out aneuploidy, I should say, and that is drastically reducing the percentage of twins and certainly the percentage of triplets or more. So IVF, we really have limits on FSH and estradiol when we start. So we do that day 2 testing for egg reserve. And FSH and estradiol vary per cycle. And so we know that if the estradiol is high, greater than 70, if the FSH is greater than 15, chances of success in stimulating a woman for multifollicular development is really quite low. And so that's how we determine whether or not to initiate cycles. We don't base it on age alone. If a woman is using donor eggs from a younger woman, then we can do donor egg IVF up until the age of 55. Donor egg IVF or donor embryo IVF has really, solidifies the notion that the uterus is fine in older women, that infertility is really an age-related phenomenon for many women when they are older. So the protocol uses those same injectables, but this time we are giving higher doses to stimulate as many follicles, as many eggs to grow as safely possible. We add on additional medications to prevent ovulation because we actually want to go and retrieve the eggs surgically and combine them with sperm in the lab. So this is the unstimulated ovary with the antral follicles. We give the injectable medications. The woman takes them at home daily, and the follicles grow. We measure the follicle growth as a proxy of egg maturity. Follicles that are about 18 to 20 millimeters in size are considered to have mature eggs. We then go in and do an ultrasound-guided retrieval. So there's a needle along the probe of the vaginal ultrasound. The needle goes through the vaginal wall into the ovary, removes this follicular fluid. We give the fluid to the embryologist, and they look under the microscope for an egg. In the lab, we combine eggs with sperm for routine insemination. This is a mouse egg, not a human egg. But what you see here is multiple sperm trying to penetrate the egg. If we have abnormalities in the semen analysis, if we believe there's a significant male component to the infertility, we will perform intracytoplasmic injection. That's injecting a single sperm into the egg. So we have a holding pipette holding the egg steady, and there's a tiny sperm in there that we are now piercing and depositing in the egg. Doesn't lead to 100% fertilization, but certainly increases the chances that the DNA are going to combine, and that we will, the day after fertilization, we have 2 pronuclei, showing that there's successful fertilization, a 2PN stage. By day 3, the embryo a normal embryo has 6 to 8 blastomeres. If we were to take one of these blastomeres away and do genetic testing, it represents the entire embryo. But there's the whole issue of mosaicism, and so what has happened now is most biopsies are done of the trophectoderm, or the trophoblast layer, on day 5 or day 6 of embryo life. By day 5 or day 6 of embryo life, a normal growing embryo should be a blastocyst with a well-developed inner cell mass, the blastocele cavity, and a nice trophectoderm. And so when we do the biopsy now for preimplantation genetic screening for aneuploidy, or preimplantation genetic diagnosis to diagnose a single gene defect like sickle cell or the presence of a cystic fibrosis mutation, we're taking biopsies from here. Logistically, the biopsies are done. All of the embryos that are biopsied are frozen, and the woman waits for the results and doesn't have an embryo transfer during this cycle. And that we would then wait for the results, discuss the results, and that she would need another cycle where just we've prepared the uterus to receive the embryos. So a much less, it's called a frozen embryo transfer cycle, much less intense in terms of there's no daily medications, there's not all this ultrasound monitoring, but it really has improved our successes with IVF, especially in older women. So a single one of these is what we ideally like to transfer in. There is a chance that this one embryo could split into 2 identical twins. The incidence of monozygotic twinning is higher after IVF than it is in naturally conceived pregnancies. And so the embryo transfer is really taking the embryos in a transfer catheter and gently placing them in the uterus. And so one thing we have to always remind patients of is that it's a transfer, it's not an implantation. The embryos still need to talk to the uterus and, implant. And so it's not 100% success that we're going to have, implantation, and certainly not a live birth at the end. But this is an ultrasound at about 7 weeks where we have a singleton that is appropriate. So oftentimes people say, well, how many IVF cycles do I need to do? When should I stop? We've looked, and it looks like, sort of after 6 cycles, the cumulative pregnancy rate starts to plateau. Whether or not someone should do 6 IVF cycles, there's a lot that, plays into that, sort of the emotional, mental, financial aspects of it. There's no harm. There's no accelerated depletion of egg reserve, but that is a lot of IVF cycles. So if we look at the outcomes, there's a lot that goes into the process. That we stimulate the ovaries, we have an egg retrieval. So women less than 35, 94% of women are going to be successful, have an egg retrieval, and that will result in about 86% of them actually having embryos transferred in, 47% with a pregnancy, and then 40% with a live birth. So here is the loss with spontaneous miscarriages. Now when we start to look at the 41 to 42 age group, 85% will actually have a retrieval, but then 72% are having a transfer with a 20% pregnancy rate and a 12% live birth rate. So you can see that, with using your own eggs, using your own embryos, that there really is a decline in the success that we get with IVF. This is all comers, but just based on age. We don't have a cap, as I mentioned, for age. If hormones are normal, we will do IVF cycles. But, we sort of go back and forth of, after the age of 44, even between 43 and 44, should we still be so readily offering IVF cycles with a woman's own eggs? And at 43, 12% pregnancy rate, but 6% live birth. Greater than 44, a 4% pregnancy rate and 1% live birth. But, sort of these are things that most women between 40 and 45 will try. If they are responding to the medication, that we will try, because this is certainly not zero, but we do try and sort of keep it into perspective in terms of how many IVF cycles and what the overall likelihood of success after the age of 44 is in terms of a live birth. So, thank you. Yes. Hand has gone up. Yes, please.
Other than the disorders where the woman is in pain, or is it progressive condition of
Endometriosis?
okay,
That kind of pain? Yeah.
which are covered by insurance and which are paid out of their pocket?
Right. So a lot of fertility. So in New York, most commercial insurance companies will cover fertility treatment. Most of the companies will cover the diagnosis, the stimulation, and inseminations. It's now making the jump to IVF, where the level of your coverage at a particular company and different companies will vary. Sometimes there's a mandate that you have to do a certain number of insemination cycles to then qualify for IVF, but there are quite a few insurance companies that don't cover IVF. Questions? Right. Thank you. Oh. Hello. How are you? Yes, please.
Thank you for your lecture. It was really good.
Yes.
I was wondering how these numbers, the percentage that result in pregnancy or live birth, how those change when you're using a surrogate mother.
Perfect.
Surrogate mother is going to be based on the age of the egg. Based on the age of the egg.
Okay. And so.
But if you're using surrogate eggs, like donor eggs, you're down here. Because donor eggs are coming from a woman who's 20 to 32 years old.
Right. So is the chance, so for a given woman's eggs,
Yep.
Which one is it?
if you're implanting the fertilized egg into the same woman versus a surrogate woman, the chances of implantation and successful pregnancy will be the same?
Provided that she doesn't have reasons that you think her uterus is bad.
Okay.
I mean, surrogacy is much, much less common than it's the least common thing that we do,
Right.
because most of the time
Here's the mic.
a woman's uterus is a fine place. So the reason to have a surrogate is have a uterus. She's had ovarian cancer, she's had her uterus removed. She has had so many surgeries that she just doesn't make a good lining of uterus, and or she's had so many miscarriages that we're like, listen, these are normal embryos, we've tested them, we put them in, and at 8 weeks, she's losing up this pregnancy. Another reason to do a surrogate is somebody with bad pregnancy outcomes. So, for example, if she's been pregnant once or twice and has growth restricted babies that deliver really early, something is not quite right later on when her placenta is being made. So those are reasons. Otherwise, the uterus is usually a pretty good home. I mean, it's pretty clear if the uterus is a problem. So transferring into your own uterus for 95% of women versus using a surrogate would be about the same.
And then the big drop off from well, I just meant like the big drop off from being able to create a fertilized egg versus to having a live birth. That comes from failures of implantation mostly.
Mostly aneuploid.
Oh.
Mostly aneuploid.
So they'll actually it'll implant and then it'll have a
Or not,
spontaneous
or not implant at all. That you make embryos that are actually aneuploid. I mean, we see this with donors, that if we were to test all of the donors at age 22, a huge portion of their embryos are not normal.
Right.
And we usually in IVF, so just to give you examples of numbers, let's say we have 15 eggs retrieved, we probably only make 2 blastocysts.
And it's not possible to test for aneuploidy at the level of the egg?
No, because what happens is you need the egg machinery to go awry. Then you have an abnormal embryo. And that's what it is.
Okay. Thank you.
You're welcome. Well, hi! It's nice to see you. I looked up, I was like, oh my goodness, I know her. How are you?
I'm great. How are you?
Good. Things going really well?
Yes.
I was about to literally. I was talking to my little girl now. She is delightful. I actually saw Liz like leaving church. Was it Easter? I don't know if it was Easter, but like a few weeks ago, I was like, oh great. Did you spend any time with them?
Every once in a while, I dinner Susan maybe a month ago, but I'll spend like nearby my husband.
Good. I'm glad. Yeah, you too. All right. Yes, please.
think so.
It's not that the pill has been causing.
Yeah.
It is. I think it's the same-ish.
It's all in there.
Okay. Let me just look through mine.
Oh, yeah, of course.
Just to make sure, because otherwise we
Yeah,
switch
we
to
can,
this.
yeah,
just
of
'cause
course. Sure.
I've got a couple of.
No, we can do that in 2 seconds. I've gotten very,
Great.
let me take that one out, and then, because I think there have been some. Let me see if this is dragged onto. Actually,
Just I went through the click throughs.
for some reason, I think only the bottom. We can try it. I think for some reason, only the bottom one is the most. Oh.
That's it. Touchscreen. Lexar. And then there's the mouse. It should be Acne folder, yes. Yes. Can I save it on the desktop? Or you can just drag it from the. I should just put it here. And then we can open it from there. And then I could open it from, let's close it out. This is hers. Right, we want hers back. But then also let's just, I'll let you. I'll just put it on the. Thank you. I'll put hers back. Right, so she's ready to go. Thank you so much.
I have a water bottle. What did I use? I don't want to pass out up here and fill my head. You just tell me when. I forgot I had this on. Do you want to put that in your pocket? Oh yeah, it's time. The little boys. No, I won't really move. Oh, I guess maybe I will. Hello. Hello, okay. Alrighty. Hello, good morning. Good morning. We're going to go ahead and get started because this is an action-packed hour. We've got both hirsutism and acne in this lecture. I'm Dr. Paige Wilson. I'm here from the Division of Endocrinology, and I'm going to talk to you about hirsutism for the first half of the lecture, and then Dr. Morell from the Department of Dermatology will talk to you about acne. So we're going to start off with a case. This is a 25-year-old woman with no significant past medical history who showed up to an endocrinologist's office complaining of increased hair growth, She noticed it on her chin and on her breasts, and she's also noted more pimples than usual and states that some of them have white pus. She thinks she's always had more hair and pimples than her friends, but over the past few months, things really seem to be getting worse, and she wants to know if there's something the matter with her that can potentially be rectified. So the objectives for this portion of the talk are to understand the pathophysiology of androgen-mediated hair growth, to understand the potential causes of hirsutism, and to learn about the medical management of hirsutism. So you only have to look around the next time that you are riding on the subway to realize that hirsutism is relatively common in reproductive age women. About 5 to 10% of reproductive age women are hirsute, as defined by the presence of excessive terminal hair that appears in a male pattern in women. And when we grade hair growth clinically, we typically use a Fairman-Gallwey score. And what this scale allows us to do is it looks at 9 different areas that are androgen sensitive on the body: the upper lip, the chin, the chest, the upper abdomen, the lower abdomen, the upper arms, the thighs, the back, and the buttocks. And it gives a rating to hair growth on a scale of 1 to 4. The total possible score is 36, and anything greater than 8 over 36 is abnormal in the U.S. population and defines hirsutism. Now, it's important to note there are some significant racial and ethnic differences in terms of what's considered normal. Women of East Asian descent and Native American descent tend to have much less body hair on average in comparison, say, to women who are of Mediterranean or Southeast Asian descent. So what's most important is not so much how much hair someone has, but really whether the rate or pattern of hair growth has changed in terms of diagnosing underlying pathophysiology. So hair kind of falls into 2 categories. Either it's vellus hair, which is fine, soft, non-pigmented hair. This is the type of kind of hair you may see if you look very closely at a baby's skin, or typically in children, versus terminal hair, which is long, coarse, pigmented hair, like the hair you see here pictured in B. This is typically terminal hairs are the types that individuals present complaining about in the setting of hirsutism. Now, while the number of hair follicles on a person's body is relatively fixed at around 5 million, the type of hair can change, and androgens generally induce vellus follicles in androgen-sensitive sites to develop into terminal hairs. So what you'll see is androgens increasing hair growth after puberty in places like the upper lip, the chin, mid-sternum, upper back, sideburns, inner thighs, and buttocks, all of those places, aside from the sideburns, that are sort of featured in the Fairman-Gallwey scale. Interestingly, in the scalp region, androgens actually lead to hair loss. So in women who are hyperandrogenic, you may actually see male pattern baldness. So when we think about the pathogenesis of hirsutism, it's important to think about the pilosebaceous unit. This includes the sebaceous gland, hair shaft, and follicle. And what happens is that in the presence of androgens, a prepubertal vellus follicle differentiates either into a terminal hair or a sebaceous gland with a hair that basically remains vellus. So prior to puberty, you have vellus hair, you have very small sebaceous glands, and then once androgens are present, the pilosebaceous unit will form either a large terminal hair follicle in the areas of sexual hair or a sebaceous gland in non-sexual hair areas. And Dr. Morell will talk to you more about the sebaceous gland and its involvement in the pathogenesis of acne. So it's very important to realize that the presence of hirsutism depends not only on the presence of androgens, but also on the sensitivity of the hair follicle to androgen. And what this really means is that the severity of hair growth doesn't always correlate with the level of androgen. So you can have women who are quite hirsute who actually have normal levels of androgens, and this is called idiopathic hirsutism. And then you have women who actually have elevated levels of androgen in the blood, but don't really appear that hirsute, although most typically do. So when we think about the major androgens in women that are involved in the pathogenesis of hirsutism, this is basically the list in terms of decreasing order of concentrations. DHEAS, which is a sulfated form of DHEA, arises from the adrenal glands. Androstenedione, also adrenal and ovarian in origin. I'll talk to you a little bit more about that. The first three here are really pro-androgens, and so what that means is that they need to be converted to testosterone to really exert their androgenic effect. Testosterone and DHT, which primarily arise from the ovaries, have androgenic capacity at baseline. Testosterone is converted by 5-alpha reductase to DHT, which is the most potent androgen, and essentially has 3 times greater the affinity for the androgen receptor than testosterone. In terms of concentrations, DHEAS is actually present in about 250 times the concentration of testosterone. So this is a schematic of androgen biosynthesis, and you don't need to know every single step in this pathway, but what you do need to understand is that, like other hormones, androgens arise from cholesterol. DHEA, which is an adrenal product, as I was saying, and androstenedione, which comes both from the adrenals and ovaries, both are ultimately converted into testosterone and then into DHT via 5-alpha reductase. The binding protein for testosterone is SHBG, or sex hormone binding globulin. Understanding the relationship between SHBG and total testosterone and free testosterone is very relevant, because ultimately total testosterone is bound to HSPG, free testosterone is not, and free testosterone is really the androgenically active form of testosterone. So it's very important for you to kind of know what physiologic states affect SHBG and how they impact it. So typically in the presence of androgens, SHBG is lower. You also see low levels of androgens in the presence of obesity, cortisol excess, and hyperinsulinemia. So all of these states lead to elevations in free testosterone and potentially to hirsutism. In contrast, high SHBG is increased by estrogen, so in the setting of pregnancy, in the setting of exogenous estrogen, in the setting of cirrhosis, which is a hyperestrogenic state. That's why you see the polymerythema. And anorexia, which also raises SHBG, and that's independent, as you can imagine, of estrogen. So where do these androgens come from in women? Well, I've alluded to it, but this slide really speaks to the physiology. So the anterior pituitary secretes ACTH, and this ACTH stimulates the adrenal production of DHEAS. The adrenal glands are responsible for the majority of DHEAS production. And this is relevant because when you see a patient with hirsutism and you're looking at labs, when you have elevated levels of DHEAS, you really should be thinking about a primary adrenal process as the cause of hirsutism. LH stimulates the ovaries to release, to basically make testosterone. And while you can have adrenal testosterone production as well, when you see, for the sort of simplification purposes, typically when women have elevated levels of testosterone in the blood, you're thinking about a potential ovarian cause for their hyperandrogenism. So what's the differential diagnosis for hirsutism? What diseases do we really need to think about as potentially causing increased hair growth in women? Well, the first is PCOS, which you're pretty familiar with, I'm sure, from Dr. Wardlaw's lecture. Polycystic ovarian syndrome, idiopathic hirsutism, and hyperandrogenism are always a consideration. And then rare causes are things like non-classic congenital adrenal hyperplasia, ovarian tumors, ovarian hyperthecosis, adrenal tumors, and Cushing syndrome. So we're going to talk about each of these a little bit. So PCOS is the most common cause of hirsutism in women. That shouldn't surprise you. It's an incredibly common disorder. It affects about 10% of reproductive age women. Among hirsute premenopausal women, 50 to 80% have PCOS. So what are the diagnostic criteria for PCOS? The criteria that we currently use are the Rotterdam criteria. There are 3 main criteria, and out of these you need 2 of 3 to make a diagnosis. So the criteria are oligo or anovulation, and that means less than 8 menstrual cycles a year. Biochemical or clinical evidence of hyperandrogenism, so you can either have high levels of androgens, or you can have evidence, clinical evidence of hyperandrogenism, things like acne, hirsutism, are really the primary manifestations of hyperandrogenism in PCOS. And then the third criteria is polycystic ovarian morphology. And what you see over here is a polycystic ovary. This is on a high-resolution transvaginal ultrasound. And what you see are the characteristic follicles, and they're typically in polycystic ovaries, there are at least 12 follicles. The distribution is often a sort of string of pearls, described as a string of pearls or along the outside of the ovary, or as a chocolate chip cookie. It's important to realize that you can have PCOS without having polycystic ovarian morphology. You don't have to have it for the diagnosis. It's also important to realize that you can have polycystic ovaries and not have PCOS. And about 25% of reproductive age women actually have polycystic ovarian morphology but don't have PCOS. The most important part of the diagnostic criteria is really the exclusion of other disorders. This is the key. You cannot, PCOS is a diagnosis of exclusion. You cannot make this diagnosis until you exclude other potential causes of hirsutism, hyperandrogenism, menstrual irregularity. And this is actually, I highlight this because this is a common problem. I treat a lot of patients for Cushing's. The majority of them appear in my office with a long-standing diagnosis of PCOS. And they've never been ruled out for Cushing's, which is what they actually have. So this is important. So when we think about androgen excess in PCOS, it usually manifests itself during puberty, when LH pulse frequency and amplitude are increasing and ovarian steroid production increases. This is sort of a classic picture of a patient of PCOS. With PCOS, you can see that she's got facial hirsutism on the chin and upper lip. She has a small amount of acne on the forehead. She's also overweight, and that's common in about 50 to 80% of patients with polycystic ovarian syndrome, although it is by no means a requirement. There is a lean PCOS phenotype. She also, maybe we can say, has a little bit of acanthosis, suggestive of insulin resistance, and insulin is I'm sure Dr. Wardlaw talked to you about the fact that insulin is somewhat central to the hypotheses regarding the pathogenesis of hyperandrogenism in PCOS. So in these patients, you're typically going to measure most androgens, but total testosterone is really always something that you're going to measure. Free testosterone labs can be considered, but commercial free testosterone labs assays are actually quite limited at this point in time. So while some groups will recommend it, most people typically just measure total testosterone in women. The assays aren't reliable for free testosterone in women. It's important to have some sense of what kind of levels are diagnostic of one disease or another. And in PCOS, it's unusual to see a serum total testosterone level that's greater than 150, and that's important, nanograms per deciliter. So idiopathic hirsutism is another common, unfortunately, cause of hirsutism. This is a diagnosis for women who are hirsute but actually have normal androgens. And as we talked about, this may be related to sensitivity of the hair follicle to androgen, or may result from upregulation of the androgen receptor. It also may result from upregulations of 5-alpha reductase activity, so increased conversion of testosterone to DHT. We typically don't measure DHT. There aren't commercial assays, so this isn't something that clinically you diagnose, but it is a potential pathophysiologic mechanism for idiopathic hirsutism. Congenital adrenal hyperplasia is another potential cause of hirsutism. This is infrequent and accounts for, there's a range, anywhere between 1 and 15%, most studies will say, of hirsutism in premenopausal women. I think 15% is on the high end. Just in clinical practice, it's something that you diagnose relatively infrequently. So I would say it's somewhere on the order of 1 to 2% in terms of an etiology for hirsutism in premenopausal women. It's an autosomal recessive disorder, and it involves deficiency of an enzyme that's involved in cortisol or aldosterone synthesis. There are two forms of CAH, classic CAH, which really I'm going to talk about just a little bit, but sort of it presents in infancy, so it's really something you're thinking about in a pediatric population as opposed to sort of a post-pubertal adult female population. And then there's the non-classic form or late onset CAH, which is really more relevant in the population that we're speaking of. So this slide speaks to the diagnosis of classic CAH. The majority of cases, about 95%, result from 21-hydroxylase deficiency. The deficiency is more severe in the case of classic CAH, which is why it basically, the enzyme deficiency, which is why it presents in infancy. You can see here that, that if you block this enzyme, progesterone isn't being converted to aldosterone, and you're not getting 17-hydroxy progesterone conversion to cortisol either. So you see both salt wasting with hyponatremia and failure to thrive. You see adrenal insufficiency with low cortisol levels, and the majority of substrate is being basically shuttled into androgen synthesis. So you get high levels of 17-hydroxyprogesterone. Those are actually diagnostic of CAH. You get high androstenedione levels and ultimately high testosterone levels. In infants, this appears in girl infants as ambiguous genitalia, which you see at birth, and boys typically present later on, around 2 to 4 years, with early virilization. You treat these patients by basically replacing glucocorticoid and mineralocorticoid replacement. Now, non-classic CAH presents later in life, and the reason why is because the enzyme deficiency is much less severe, typically on the order of 20 to 50%. And so they do have decreased production, slightly decreased production of cortisol and aldosterone, but it typically leads to an upregulation of ACTH, and so they're able to maintain normal glucocorticoid and mineralocorticoid levels. They do, however, have high levels of 17-hydroxyprogesterone that get shuttled into androgen synthesis, and so they have high levels of testosterone. So how do these people present? They're a lot like some of the PCOS patients. The majority present with hirsutism and menstrual irregularity. Acne occurs in about 1/3 of them. Infertility is common, although most are able to conceive with glucocorticoid replacement. And clitoromegaly is typically, or is present in about 1 in 10. And this is important because clitoromegaly really isn't something that you're going to see in a PCOS population. That can kind of be a clue that you have something else going on. Now, androgen-secreting tumors in general are much less common causes of hirsutism, but they're quite relevant, obviously because they're much more severe and need to be treated aggressively. So androgen-secreting ovarian tumors account for about 5% of all ovarian tumors. About 0.2% women who have hirsutism actually have an underlying androgen-secreting ovarian tumor. These are typically tumors that are of the sex cord stroma, like Sertoli or Leydig cell tumors, granulosa or thecal cell tumors, or Hylas cell tumors. A hallmark of androgen-secreting tumors is that the testosterone concentrations or androgen concentrations are high. In women who have ovarian tumors, the testosterone concentrations are generally higher than 150 nanograms per deciliter. The other thing is that these tumors tend to occur later in life, so after the 3rd decade of life, and the onset is rapid. These people come in presenting with symptoms of rapid onset of virilization, growth of a beard kind of overnight, voice changes, clitoromegaly. So you're kind of, the clinical picture is typically much less insidious and much less aggressive, and much more aggressive. Ovarian hyperthecosis is primarily seen in postmenopausal women, and you may all know this, although sometimes I'm surprised. PCOS can't be diagnosed in a postmenopausal woman. It's a diagnosis of premenopausal women, right? It requires menstrual cyclicity. But ovarian hyperthecosis can be seen in postmenopausal women. So it presents with progressive hirsutism, acne, and virilization, high testosterone concentrations over 150 nanograms per ml. And it's important to realize the normal testosterone levels are typically in most assays less than 60 in a woman. In a man, they're typically above 250, 270, just to give you some perspective. Ovarian hyperthecosis is caused by an increase in testosterone production by luteinized theca cells in the stroma. Here is one represented here in this sample from the ovary. And typically, if you get an ultrasound in these patients, instead of seeing sort of a polycystic ovary, you'll see an enlarged ovary with an increased stromal volume. So the other potential tumoral cause of hirsutism is androgen-secreting adrenocortical carcinomas. 60% of adrenocortical carcinomas present with hormone excess. In terms of what's relevant to hirsutism, that would be hormone excess in the form of Cushing syndrome, in the form of androgens alone, or a mixed Cushing's androgen excess picture. This is a rare cause of androgen excess. It's a relatively rare form of cancer, but it presents with rapid onset viralization, hirsutism, acne, clitoromegaly, voice change, marked change sometimes in muscle mass. Dr. Kura has a very interesting case of a patient with adrenocortical carcinoma who presented with hirsutism and change in muscle mass, a woman. And the secreted androgens, because it is adrenal in origin, are DHEA and DHEAS, and they tend to be high, greater than 700. The upper limit of normal of DHEAS is in the high 200s. So ACTH-dependent Cushing syndrome is probably the last cause that I'll talk about of hirsutism that needs to be ruled out, and it is caused by an overproduction of ACTH, either from a pituitary source or an ectopic tumor, and it results in cortisol excess, and the high levels of ACTH also stimulate adrenal androgen production. Because, like we talked about earlier, cortisol decreases SHBG, you typically also see higher levels of free testosterone in these patients. And this picture sort of is the classic Cushing's patient. You can see that she's got facial hirsutism of the upper lip and of the chin. She's got the moon face and the hyperpigmented striae. But facial hirsutism is very common in this population. I'm going to talk to you just a little bit in the remaining time about the pharmacologic management of hirsutism. I do want to stress often when patients have hirsutism, they may come to you already on oral contraceptive pills. In terms of measuring androgen levels, that actually needs to be done off the pill to be accurate. And so, because obviously the presence of estrogen and progesterone are going to decrease LH and FSH and are going to decrease endogenous testosterone levels. So, how do we manage hirsutism? Well, the oral contraceptive pill is really sort of the bedrock of hirsutism management. We also use anti-androgens, and in rare circumstances, sometimes use glucocorticoids. So OCPs, these are the recommended initial therapy for women presenting with hirsutism or premenopausal. Transdermal preparations, like the patches, are equally effective. And so what's the mechanism of action? Well, obviously giving estrogen and giving progesterone basically turns off LH secretion. And so you inhibit LH-dependent androgen production. And as we talked about before, high levels of estrogen stimulate SHBG. In the presence of increased SHBG, you bind testosterone levels and decrease free androgen, free testosterone. So how do you pick a pill? There are hundreds. Literally. It's very important that you pick a pill with a higher concentration of ethinylestradiol, and this is mostly because at higher concentrations you'll have greater success at stimulating increases in SHBG. So the pill usually needs to be a 30 to 35 microgram pill, and then you have to be thoughtful about the progestin that you select. You want one that has low androgenicity, obviously. So levonorgestrel is actually kind of has potent androgenic activity. This is something that you want to avoid, and you want to choose something more like norethindrone acetate or ethanoidal diacetate. Drospirenone has no androgenic activity. It actually has anti-androgenic activity, and we'll talk about that a little bit. And this is the progesterone is typically found in pills that are sort of promoted for PCOS, like Yasmin and Yaz. So anti-androgen therapy. So the best anti-androgen therapy that we have access to is really spironolactone. And most of you probably know of spironolactone mostly as a case-sparing diuretic, decreases sodium, absorption and K secretion at the level of the distal tubule, but it's also, in addition to being an aldosterone antagonist, it's an androgen receptor blocker. It's a competitive inhibitor of the androgen receptor and also works to inhibit 5-alpha reductase to some extent. So patients who are treated with this medication typically will see a Fairman-Gallwey scale reduction of about 15 to 40% in 6 months. There is obviously a risk of hyperkalemia based on the drug's mechanism of action, and the other risk that's very important to know about is that of pseudohermaphroditism, say that 5 times fast, in male offspring who are conceived if the patient is taking the pill, spironolactone. So it's really critical. Usually when you start patients on spironolactone, because these are premenopausal women, most are sexually active, you usually administer this to people who are already on a birth control pill. You can use it independently, but clearly with great caution. So drospirenone is a weak androgen receptor antagonist. It has kind of a fraction of the effectiveness of spironolactone, but nonetheless, it's not, we can't obtain it sort of independently, but it is present in, like I said, Yasmin and Yaz. So proterone acetate is actually an awesome drug. It's an androgen receptor antagonist and also a 5-alpha reductase inhibitor that works very well to treat hirsutism. It's actually used probably in the majority of countries for the treatment of hirsutism, often in a combination birth control pill called Diane. It's not approved for use in the U.S., but if you see international patients with hirsutism, often they're on it already or have access to it. There have been some recent concerns about it potentially increasing clot risk, much like Yasmin and Yaz, just so you know. So the last anti-androgen therapy is finasteride. This is a more aggressive 5-alpha reductase 2 inhibitor, decreases testosterone to DHT conversion. Ultimately, though, in women, the hirsutism reduction is comparable to what you see with spironolactone. This is Propecia. You guys may know this is used typically more commonly in men, but there is an off-label use in men for baldness, male pattern baldness. There is an off-label use for using it to treat women with hirsutism by reducing DHT synthesis. So rarely we use glucocorticoids to suppress hirsutism, and this would be applicable in a population of women with non-classic CAH. It's important for you mostly just to understand the mechanism by which this would work, which would basically be that by giving steroid, you inhibit ACTH release from the anterior pituitary, and so decrease endogenous DHEAS production at the level of adrenal. Unfortunately, glucocorticoids are associated with an array of side effects, and so usually OCPs and anti-androgens are what we would start with first, even in a patient with CAH. So in summary, hirsutism depends on the presence of androgens and on the sensitivity of the hair follicle to androgen. PCOS is the most common cause of hirsutism, but is a diagnosis of exclusion. And less common, but potentially more serious causes of hirsutism really need to be considered first before this diagnosis can be made. OCPs and anti-androgens are really the bedrock of the treatment of hirsutism. So in terms of the case, the patient had a full endocrine evaluation done, but sadly it was negative. So she decided to undergo laser treatment for her excess hair, and now she's going to see dermatology for further assessment and treatment of her acne. Thank you. Dr. Morales.
So let's see, let me just end share. Give me a second. Thank you. And then here it is, right? Yeah. Thank you so much. That was a great segue into the next part of the talk. Kimberly Merrill from the Department of Dermatology. I practice pediatric dermatology here, and I'm going to talk to you about acne vulgaris. I do have one conflict of interest to mention. I was on a Galderma Acne Advisory Board meeting, but I'll just be talking about generic forms of medication today. So our goals today, we're going to talk about some of the basics of acne pathogenesis, to learn to recognize when acne is associated with endocrine dysfunction, which Dr. Paige Wilson already did a very nice job of, and to understand some of the initial treatment strategies we have for our acne patients. So just to give you some background in epidemiology, acne has a prevalence of 85% in younger patients, and it can be moderate to severe in up to 20% of teenagers. But it's not just a disease of teenagers. As you can see, it can persist into the third, fourth decade, etc. And lots of money is spent on acne treatment, so we like to direct our patients to the right therapies as opposed to just going to the pharmacy and picking up what's marketed to treat their acne. So let's dive down into the skin. This is the pilosebaceous unit. Your basically hair follicle plus sebaceous glands makes up your pilosebaceous unit. And just to orient you, when you look at your skin in cross-section, up here is your epidermis, and down here your hair follicle dives down into your dermis. And in here is what we call your keratinocyte debris. So you can see, right, your outermost layer of your epidermis, right, is your stratum corneum that you slough off your skin every day, and that's contiguous with the lumen of your hair follicle. So in here we call it your keratinocyte debris. And then these collections or clusters of foamy cells are your sebaceous glands, and they produce your sebum, which drains into the sebum into the follicle lumen. So what is happening when we develop acne? First of all, androgens play a key role. They increase your sebum production. So this happens normally at puberty, and some patients have excess androgen, and some patients, again, you heard, can be more susceptible to the effects of androgen even at normal levels. This leads to altered keratinization in that hair follicle, and that keratinocyte debris forms a plug. And then the P. acne bacteria also plays a key role. It loves to live in the lumen of that hair follicle and contribute to inflammation. So this skin pore in cross-section looks a little different than the one I just showed you. This one is now packed with keratinocyte debris that's formed a plug because of, again, that sebum that's produced into the lumen. The P. acnes bacteria are just thriving in that anaerobic environment in there, and there's little to no inflammation. And then as time goes on, potentially you can get, this is an inflamed acne lesion that you can see the lumen of the follicle has been disrupted, so all of that sebum and free fatty acid has been liberated into your dermis, and tremendous inflammation around that pilosebaceous unit. So again, just in the smallest number of words possible, this is your 4 key factors in acne pathogenesis. Again, androgens, sticky keratinocytes, P. acnes, and inflammation, all 4 are present for acne to develop. And then in terms of some morphology, and we'll go over some pictures to review, but those early lesions or little to no inflammatory lesions are your comedones, open and closed. And then when the inflammation happens, we develop clinically pustules, papules, nodules, and cyst. And then scars are our secondary morphology, right? They develop post-inflammatory hyperpigmentation and atrophic or hypertrophic scarring afterwards. So here's an example of your open comedone or blackhead, and you all know this is not dirt in your pore, right? So if you look at that lesion in cross-section, it is just a pilosebaceous unit with a very dilated follicular opening packed with keratinocyte debris. And then your whitehead. Here is really a similar lesion. The difference is that you don't see that open lumen. It's there, but it's not necessarily visible to your unaided eye. And these lesions are felt to be a little bit more likely to develop into an inflammatory lesion because the keratinocyte debris has nowhere to go, and again, more susceptible to inflammation around that lesion. So inflammatory lesions, here are some pictures of patients with erythematous papules, pustules. Again, that's correlates with that picture I showed you in cross-section with tremendous inflammation around that lesion with scarring potential. And then we have nodules and cysts. These are the ones that have tremendous scarring potential that can leave behind deep erythematous lesions where the erythema eventually fades but can leave behind permanent atrophic scarring. So, factors that contribute to acne, right? We ask in our history, what are you using on your skin? Let's make sure everything your patient's using is non-comedogenic or won't clog your pores, but that's not a common occurrence. More importantly, we want to be keyed into to look out for patients where their acne may be a sign of endocrine dysfunction. We heard about PCOS, we heard about congenital adrenal hyperplasia, we heard about androgen-secreting tumors. And then again, we always want to take a good medication history. Medications can certainly cause acne eruptions. For example, is our patient on prednisone or steroids for a medical condition that can certainly cause or flare up their acne. You want to ask them, are they taking anything that they shouldn't at the gym with their trainer? Because that can certainly be associated with difficult to control acne. And then in psychiatric patients on lithium actually is one cause of difficult to control acne. And then believe it or not, immunosuppressive agents such as cyclosporin and sirolimus you'd think would help decrease those inflammatory acne lesions, but it can most be dysregulated, and patients on these medications can also have severe acne. And then antibiotics, isoniazid and rifampicin are two of the antibiotics that are known to be associated with acne development. Then you may see acneiform eruptions also on your oncology rotations. Epidermal growth factor receptor inhibitors are associated with acne and acne-like eruptions, which is not a rate-limiting factor for treating your patient, but sometimes patients need medical acne therapy to help them get through their course if they have more than mild acneiform eruptions. All right, in our evaluation, again, in our history, when did acne start? Is it starting at the time that you'd expect it, when puberty is beginning, or is it precocious before age 8, for example? What products are they using? What medications are they on? What are their menstrual irregularities? On exam, not just are they showing signs of hirsutism on exam, but do they do any methods such as have they had hair laser hair removal or something that may be masking the fact that they do have an underlying hirsutism that they're controlling with hair removal methods. Again, look for stria. We look at our secondary sex characteristics, virilization, precocious puberty. And again, think about these patients and as we may need to test them or send them to an endocrinologist for further evaluation before we just prescribe medical therapy for their acne. So, in terms of acne treatment, where do we start? Again, think about those 4 main factors in acne pathogenesis. We really want to try and target each one of these factors for our optimal improvement for our patients. So just talk about some readily available over-the-counter products. Benzoyl peroxide we like because it's bactericidal for the P. acnes bacteria. So this is really, I call it your workhorse for acne therapy. Available, again, in many over-the-counter products and a good first choice. Other things you'll see over the counter are salicylic acid and glycolic acid in your medicated acne washes. These can help. Again, these are not scrubs. These are ingredients in your cleansers that can help decrease those sticky keratinocytes and help the lumen of your hair follicle drain as it should. And then we get into prescription therapy. Really, topical retinoids, when you have more than mild acne, are generally your go-to to help even with those comedonal lesions that we talked about. Tretinoin, right, is the mainstay. The way it works is it normalizes the maturation of that follicular epithelium. So again, you're not getting that sticky keratinocyte plug in the lumen of your follicle. So the idea is it prevents formation of that comedone.
Adapalene is not a true retinoid, but it binds to the retinoid receptor and has similar effects to the tretinoin. The head-to-head studies, it tends to be a little less drying. So for a patient with an oily skin type, you might pick your tretinoin cream, but a patient with a more sensitive dry skin type, you might pick a different formulation. And then there's tazarotene, which in a very strong concentration is indicated for the treatment of facial acne. Very potent retinoid. You have to be aware that it is a pregnancy category X, so you need to be counseling your patients about this and watching out for it. These retinoids, you don't just write a prescription, send your patient on their way. There can be tremendous side effects. You need to warn them that they need to use just a very small amount because, again, it can be very irritating. Again, your not only follicular lumen is aided with the treatment, but your stratum corneum also is desquamating a little bit more, so you're more photosensitive. And then you warn patients not to use this product at the same time as benzoyl peroxide because it inactivates it when you use it together. So you could be using two great acne products at the same time and they just are useless. So they're working on products that have more stable formulations to be used together. And we warn all of our patients, even if you're not putting the tretinoin or other retinoid on your periocular area, it gets into your pores and it can make you very sensitive, and you can, if you were to go for a waxing of your hirsutism, you would peel off a top layer of skin as well. So something to watch out for. Again, so prescription acne therapy, there are different formulations in different concentrations that are available by prescription, but generally we direct our patients first to that bactericidal over-the-counter benzoyl peroxide product. Azelaic acid you may see about used more in acne rosacea, but it, again, be helpful against the P. acnes bacteria. And then topical antibiotic preparations. Most P. acnes is resistant to erythromycin these days. And clindamycin, if it's not resistant when you start, it can quickly become resistant if you use clindamycin as a monotherapy for acne. So generally, we always pick combination products. For example, benzoyl peroxide plus clindamycin is what I would always recommend. And if you don't use it in prescription combination, if you use it in a single as a monotherapy, always have your patient also use benzoyl peroxide in addition, even if you're not using a combination prescription product. All right, so question though. So our audience response isn't set up, but I'm going to ask you to do a raise of hands for this question number one. So a 17-year-old girl with mild inflammatory acne presents for an evaluation. She's been using a topical benzoyl peroxide clindamycin preparation to avoid P. acnes resistance for 3 to 4 weeks, 3 weeks here, without minimal improvement. So the next appropriate step, do you think, is A, continue therapy without changes, B, add tazarotene cream, C, add tetracycline orally, D, add doxycycline orally, or E, add an oral contraceptive? So let's see, who thinks A? This is a pretest. I haven't gone over the answer yet. So don't be afraid to raise your hand. Who thinks B? Who thinks C? Who thinks D? And E? Okay. So the key here, so hidden in this question was mild, okay? The answers would be more broad if I gave you moderate to severe, but this is a mild patient, so we're going to stick with topical therapy. So the pretest part that I didn't tell you yet is that your acne preparations do take a good 6 weeks to kick in. So we commonly get teenagers who come in and say, I've been using my therapy for 2 weeks, it didn't help, that treatment didn't help. So, you know, we sort of dive into the history when they say this treatment didn't help me, how long did you use it for? So the idea is they may have been using a very good therapy, they just didn't use it long enough. So the answer is A, continue therapy without changes. Again, tazarotene would be more a patient with more moderate to severe, and again, watch out, she's 17, we need to check a pregnancy test and warn her about pregnancy prevention while she's on it. And then again, oral treatment, more moderate to severe, and same with, we'll talk more about oral contraceptive treatment. So again, here's your answer A. So systemic antibiotics. So now your patient does turn out she's used her treatment for more than 6 weeks. She's now developing more acne cysts. So our next step may be to talk about adding on some systemic antibiotics here. And of the antibiotics in the cyclin categories most often used, doxycycline is the one we tend to pick these days because tetracycline, there's a lot of P. acnes resistance out there, and we'll talk about more of the minocycline, has more side effects we don't like. Erythromycin, again, P. acnes is generally resistant, so sometimes we try this option for pregnant women, but it doesn't do very much. So months of therapy may be required. And again, resistance to antibiotics is on the rise, so even when you're using your systemic antibiotic, you're also having your patient use benzoyl peroxide in some form, even a wash, to help, again, decrease the risk of P. acnes from becoming resistant. So side effects to the cyclins, photosensitivity, especially tetracycline and doxycycline, GI effects we have to be careful about. Any patient on antibiotics, we warn them about risk of yeast infections. We monitor for the potential, low but potential risk for hepatotoxicity, and then there can be pseudotumor cerebri with any of the cyclin medications. And then minocycline is, has more potential risk. These, we've seen patients who have antihistone antibody positive autoimmune disease, lupus-like syndrome, autoimmune hepatitis. You can certainly get minocycline pigmentation in any patient after you use it for several months. You can get blue-gray dyspigmentation in your gingiva or in any scars that you have that are healing. So it's a temporizing medication. And then we have had patients who've been transferred into our ICU with severe DRESS syndrome on minocycline. So I'm biased against it. There are studies looking at what genetic predispositions patients might have to this minocycline hypersensitivity. But again, we tend to pick doxycycline, warn them for the rest, have our patients photoprotect for the photosensitivity. And then hormonal acne therapy, you heard a bit about for hirsutism, right? So the same, for example, spironolactone. I'm not prescribing this for my general pediatric dermatology patient. This is a patient I'm sending over to the endocrinologist for further evaluation and management. But again, it was found, as you know, potassium-sparing diuretic that had very good anti-androgen effects in patients with PCOS who were using it. But of course, tremendous risks that you heard about, hyperkalemia and the pseudohermaphrodite effects in the male fetus, so we're very cautious. And then oral contraceptives, again, moderate acne, so not mild acne, but there are certain contraceptives listed here that are FDA approved and labeled as indicated to treat moderate acne in menstruating females age 14 and up. They're listed here, but there are other, we also see improvement with other low-dose combined estrogen pills I'll mention on the next slide. And then just watch out that progestin-only contraceptives can stimulate acne, but again, we pick combined pills, even if we call it off-label use, if it's not one of the ones that has the FDA-labeled indication. Oftentimes, our endocrinologist or GYN colleagues are prescribing the lowest dose combination that they can get away with to help our patient, and after 3 menstrual cycles, there can be significant improvement. All right. So next question. A 16-year-old boy with nodulous cystic acne, so that's severe, and a family history of scarring acne presents for an evaluation. He's been on doxycycline orally for 2 months with only minimal improvement. So an appropriate statement is A, continue his doxycycline. It hasn't been long enough. B, change to a long-acting doxycycline. C, refer to dermatology for possible isotretinoin therapy, or D, refer to dermatology for laser acne treatment. All right, so who thinks A? Again, pre-test, we didn't talk about it yet. Who thinks B? Who thinks C? And then D. Yeah, so lots of C's there. So what used to be called brand name Accutane is now available in many generic forms as isotretinoin. This is a patient who would be a candidate. 2 months should be long enough to see your best improvement, and if he's really not having more than minimal improvement, he's at that tremendous risk for scarring. So we want to refer him on to think about isotretinoin. This is a medication that works on all 4 factors of acne pathogenesis. So, 1 or 2 pills a day for a 5 or 6 months course can lead to tremendous improvement in your acne. But there are lots of side effects, and so all prescribers and patients and pharmacists must enroll in this iPledge program, which you can look at online if you haven't heard of it already. The iPledge program was mandated by the FDA because even one isotretinoin pill taken by a pregnant woman can cause severe birth defects. So it's centered around documenting that pregnancy prevention knowledge is in place. And there are also other side effects we watch for. We see patients monthly during their 5-month course and check their blood work to check for hepatotoxicity, to check for hypercholesterolemia and hypertriglyceridemia. There can be effects on bone and joints. There's controversial risks regarding inflammatory bowel disease. And in the media, you hear about the idiosyncratic reactions that some people might have in terms of depression risk. So it's not a medication that we take lightly, but it is something that has helped a good number of patients. So in summary, just again, we hope you understand those 4 key factors in acne pathogenesis, and to look out for patients who may have androgen excess so that they can be appropriately evaluated and treated, and recognize that in some cases the response to your therapy may take some time before you give up on your treatment, and know when to refer your patients to minimize scarring. So that's it. Thank you.